All right, we're live, baby.
We're good.
All right. I just had the most amazing introduction I've ever done in the history of the internet, and totally went for naught because technology failed me a little bit there. Actually, it's probably this user's error because I didn't apparently hit the right buttons. But anyway, I'm excited for you guys who are here with us today. I'm most excited for the gentleman to my, I believe to my, well, actually to my right here, who is with us, Jason, who is so kind to share his time this morning on a Saturday morning over there in Virginia, I believe. Jason, just to introduce a little bit about my background with Jason, is Jason was a big influence on my career and continues to be a big influence on my career just from a critical thinking and clinical reasoning standpoint. I first really encountered Jason's work on the Soma Simple forum. Some of you guys may or may not be familiar with that, but that was a great kind of discussion forum where we could trade ideas and thoughts around different treatments and around different mindsets and really kind of challenge each other's, philosophy of science and different things around some of the going ways we were kind of looking at people in pain. And really, that was a great place to, and still not maybe as much with social media taking over a little bit more, but Diane Jacobs, Baird Dorco, Corey Blickenstaff, Jason, a lot of other names there that we could probably go on and on over. I know Jared Hall also shares a lot of that same kind of experience initially with Soma Simple, that it was this just big batch of cognitive dissonance where it was kind of challenging a little bit of the comfortable beliefs and biases that I had kind of tucked myself into in my career. And in a good way. I mean, initially I was a little bit, had that normal visceral kind of cranky reaction to somebody dare challenging the way I thought the world worked in the way of pain and in the way of caring for people in pain. But it was the best challenge that I've ever probably experienced in my career because it really helped me grow as a clinician and really be able to help and understand things a lot more deeper level than I had traditionally. So I also wanted to let everybody know and kind of congratulate Jason on his recent promotion to Colonel. He's an awesome representative of our armed forces, and we thank you so much for your service, Jason. And with that said, I'll pass it to you to introduce yourself if you don't mind, sir.
Oh, I don't. Hey, hi, everybody. Thanks, Mark, for inviting me. I'm so privileged to talk to you today. That was a pretty good introduction. The first one was really, really good, but that might have been just as good as the one you just did a few minutes ago before the video started streaming. So thanks for having me. My name is Jason Silvernail. I've been in clinical practice for 21 years in physical therapy. I'm in the U.S. Army and have been in the U.S. Army my entire physical therapy career pretty much. I've traveled all over the world and all over the country. I've practiced medicine back in the States, all over the States, different places. I'm coming to you from Southern Maryland, right outside D.C. right now. Afghanistan, the Middle East, tons of places, both in and out of our country, in the U.S. And so when I do these talks, I'm talking to you as Dr. Silvernail, not as Colonel Silvernail. So here comes my disclaimer, which I know you're excited to hear. Everything I talk about and review with you all today is my personal opinion and commentary and does not reflect the official policy or position of the United States Army, the Department of Defense, or the United States government. When my wife Carolyn hears me say that, she's like, you know what? I feel like I know that disclaimer so well from all these things that you do that I could do it. I feel like you should roll over in bed at night and go, honey, everything I'm about to tell you is my personal opinion. So she's pretty funny about it. If you ever get to meet her at one of a conference we're at, you should definitely talk to her about that. She's pretty funny. So it's great to be here. Thank you for having me.
No, thank you so much. And kind of, guys, before we get into things more, I'm trying to keep an eye on the Facebook thread as well, but I'd love to see, I see we have Sharton all the way from Norway. We have James Stark over in Michigan, Jared's here, Casey Klein, some other folks. We'd love to know where you're at, where you're coming from.
Great name.
Definitely don't hesitate. Peter Lindberg, I believe, over from Sweden. Good to have you here, sir. Let us know where you're at. And if you have any questions along the way, let us know. We'll try to get to those. I've gathered the questions from the threads that I posted up here in the group and through some that we've shared on other places. So I'm going to pose these questions to Jason. I also have some of my own questions that I'll probably see if I can find time to interject in there as well. But if you have any that come up along the way, definitely let us know and we'll try to get to those. Let's keep them appropriate and professional. Jason and I were joking. Some of his friends and family members were giving him a hard time on some of the threads he shared. So I've politely not shared any of those questions with Jason today. So we'll keep those away. Zach
Thanks. I don't
Michael.
actually know the airspeed velocity of an unladen swallow, so that's really not the kind of question I'm here to ask.
Yeah, I think there was that whole Einstein train problem, with the
Yeah, no,
relativity.
totally.
Yeah, that was getting a little bit deep, but it was nice to see folks were giving you a hard time. But I see we got Zach Gaber and Zach Michael here too. Good to have you guys. Let's start with the first question that I at least pulled up. And the first one was from Matvey Immerman. I hope I didn't butcher your name. I'm going to apologize on the front end. If I butcher your name, I spent a career getting my name butchered and continue to have it. So I apologize, but I'll do my best. But in your practice, are you doing anything different now than what you did 2 to 3 years ago?
Well, I mean, one of the things I love about some of the groups out there in PT, and I think, Mark, your group is one of them, is your ability to curate some really thoughtful people and bring those people together. There are few people more thoughtful than Matt Immerman. So thanks, Matt, for the question. It is a great question. And I will tell you that, having been in practice for over 20 years, you see things kind of come and go in popularity as things go on. And like when I first got into PT, the big thing was like Swiss balls, therapy balls. Like everybody thinks that maybe they don't remember like what a big deal that was. But man, when I first got into PT, that was a really big deal. You're looking back, it's like, gosh, that doesn't make any sense. But things change a lot. So probably every 2 to 3 years, maybe even 4 to 5, we get like a new wave of things that are popular or have garnered a lot of interest or attention. And so our industry is not different than any other industry like that. So I would say that right now, in the last 2 to 3 years, I probably spend more time being deliberate about patient engagement and motivational interviewing kind of a style than I was 2 to 3 years ago. I was doing that. I learned to do that in fellowship training, which has an intense mentorship component to it. And I was quite good at it then, but I'm trying to get better now. And I'm spending more time on the patient engagement piece of that, specifically with like a motivational interviewing kind of approach. I think that's the first thing. And the second thing is I've gotten a little less specific with some of my prescription of exercise and movement. And I try to do things more in a graded exposure kind of paradigm, not like graded exposure. Let's do a little bit more, but take the time to read up a little bit on what graded exposure means, how to control things like different contexts, how to recognize safety behaviors, these kinds of things. So I probably do a lot more of that kind of stuff now than I did 2 to 3 years ago, but no radical shifts in practice, but that's kind of a gradual evolution probably for me.
I'm curious, Jason, with motivational interviewing, because that's another part of my practice that I've really tried to. We've had a lot of talks here on this group about that and its importance of being able to kind of move people towards behavior change and different things. I'm curious who you think might be the best resources for folks here to kind of, whether it be a clinician or a group of folks that you think would be helpful to kind of interact with or check out their material in regards to motivational interviewing.
Yeah, that's a good question. So when I was deployed in Afghanistan many years ago, actually it wasn't many years ago, it was about 6 years ago, I read the 4th edition of Motivational Interviewing, which is a book like this thick. You can't carry a book that thick around with you all the time. So I had it on my little reader thing, but that was a dense read. So most of what I know about motivational interviewing comes from like the source textbook, for better or worse. I have not read the shorter version called Motivational Interviewing in Healthcare, which I think, which I get good, reports from. So I don't have like on the tip of my tongue, like the best course or anything like that. I would say that the Motivational Interviewing in Healthcare, if you're interested in it, is probably a good look and probably worth your time. I would also think about, for me, I would reach out to my professional network and find people who I think are much better than me in this space and probably can give you better advice. So Bronnie Thompson might be a great person to ask about I think she's talked about some of those things on her blog and on social media. So I'd be really interested as someone who's much more of an expert than me in this area to talk to her and say, hey, look, if you were going to recommend somebody maybe doesn't have a huge background in this, but wants to get into it, wants to learn more, what do you think their first step should be? I would trust her advice over mine. But in the meantime, motivational interviewing in healthcare is probably a great thing to check out. One of the lectures that I do as I travel around and speak is, I do like a short block on motivational interviewing and how to engage patients with that kind of stuff too.
Great.
I don't consider myself an expert, but that's what I got.
I think we're all evolving in our expertise in that arena. And that's, one of those important areas that I think, at least speaking for myself, that I didn't really recognize the importance of that communication piece and that ability to engage and move people to behavior change. That really, I think, is a huge part of what we do and an underappreciated maybe part of what we do in physical therapy. So that's good pointers. I have that book and I've read it as well. It's a great book. Definitely gives you some good foundational stuff and some applicable stuff you can do in clinic with people. And in the end, you just got to get in front of patients and talk to them about it and use it and find out where you're failing and where it's working. And just like anything, just like a manual therapy technique, you got to kind of hone your skills over time. That's no different. Communication, definitely one of those skills to be developed. But on the second part of Matt's questions, what role does manual therapy play in your practice? And what are the narratives you use with patients when you utilize it?
Yeah, it's another good question. I know that like over the past 2 to 3 years, especially, there's been a renewed skepticism about the role and value of manual therapy in PT practice. And being a skeptic myself, I think all these conversations are great. And I think there are some people who are maybe more strident about that and others that are less so. And I think that range of opinion on the topic is good. So I'm a fellow of the American Academy of Orthopedic Manual Physical Therapists. I completed a manual therapy clinical reasoning fellowship. I don't identify myself as a manual therapist because I don't have the need to associate myself with some sort of identity group that way. But I would tell you that everybody who I see in clinic gets some kind of physical exam. Many of them get a more detailed hands-on manual examination. I would say for people who seem like they have more nociceptive mechanism pain based on their history, and people for whom I need to narrow my differential diagnosis to look for referred pain, I'm spending more time on a manual examination with that patient than I am with somebody with patients who don't have those features. Do I lay someone prone and check their spine individually and their lumbar spine individually? Yes, I do. Yes, I do. If you acknowledge that referred pain is a thing, and I think that if you look at the basic science and some of the interventional studies, it's hard to deny that that's a thing. If you agree that referred pain is a thing in the world and it exists, it is very hard to both do that and say there's no role for manual therapy or manual examination for our patients. Those two opinions are not compatible. So I would say that there are a lot of people who I see who have pain in one place whose problem is in another. I can't determine that unless I use a differential diagnosis process, which involves putting some physical exam through that patient and observing symptoms. And of course, it has all the usual caveats about, the self-delusion that we might be putting ourselves through and ad hoc or post hoc fallacies. All those things are perfectly valid, but that doesn't take away from the fact that referred pain is a thing. That's not something that a manual therapy group or people manufactured to sell courses. It's a thing. It exists. If we agree on that, then some kind of manual examination to ensure that you are not trying to treat a problem that is not the right problem to treat, that's got value. Now, we can argue about how you do that. Could you do that with exercise? Could you do that with patient-generated forces, which is what the McKenzie people might say? You absolutely could, but that's not the system I was trained in. That's not the system I'm comfortable in. MDT to some degree, yes, but just generally speaking, that's what my clinical expertise is. Part of that is that manual examination and that differential diagnosis. And I've got my share of anecdotes about that like anybody else does, which I won't bore anybody with. But that's the thing. I mean, I remember going to a manual therapy fellowship program being very skeptical about manual therapy and thinking that it was all sort of a tissue of self-delusion and silliness. And, it was a Maitland-based, the U.S. Army Baylor Fellowship Program. It completely changed how I do everything in the clinic. And I went in kind of with a chip on my shoulder. I kind of had my hands up and I was ready to fight, right? It's like, so wait a minute. So you're doing this positional. I'm like, oh no, we're not doing positional diagnosis. We're not talking about some little vertebra is out of place. No, we don't talk about that. This is patient symptoms. This is a relationship between symptoms and movement. That's the basis of what manual therapy is about. And that really has, that kind of thought process clicked for me. And that's why in my clinical practice, when I see people with pain, a lot of it, especially nociceptive pain, it's all about movement. If something doesn't have movement involving in it, I'm not interested in it. You know, I don't have a problem with modalities like e-stim or dry needling. I got no issue with those things. They can all be applied in a very reasonable clinical framework, but they don't fit my process, so I don't use them. So that may have been a longer response than you wanted, but there it is.
No, that was good. I think it sounds pretty reasonable and pragmatic approach to manual therapy, and I think very evidence informed. I don't think there's any arguments, at least coming from me, with that. I think the things I liked, because I share some of the similar backgrounds as far as the Maitland training and McKenzie training and stuff. And the nice thing is that it's patient response driven. It's not like speculating over minutia of poorly interrater reliable, examination strategies and stuff. So I think there's a huge strength in those strategies, those systems, from more of a.
And we're not talking about small responses either. We're not talking about like, your shoulder hurts. I look at the shoulder moves pretty well. Lay the patient down. I passively examine the shoulder. The shoulder passively moves well. Okay, they don't have a shoulder problem. So I need to find out where the problem is. My next move is to flip the patient over. Now I'm shortening some of this to some degree for purposes of discussion. Flip the patient over and check their C-spine. I find something that is painful or does not move well, and I move it until it moves better, right? And they say, oh, well, maybe that's a little better. Okay, I'm in the wrong spot. And if I do that back and forth on the neck, maybe it's a little better. Well, okay, it's not from the C-spine. Now I can kind of rule that out and move on in my differential diagnosis. I'm looking for big, obvious changes that anyone in clinic of any level of expertise would immediately recognize as a positive change. I'm not looking for little things. I'm looking for big things. And I think that people who don't have a training in that kind of manual exam model, I think they have a lot of misconceptions about what it involves. And they often speak pretty confidently from those misconceptions. And so there's a word for that. It's the Dunning-Kruger effect, right?
Yeah, that is it defined for sure. And I think, there is definitely, these two camps that, manual therapy, we got to hold on to all these traditional dogmatic stuff. And then there's the other, spectrum of it sucks and we should be getting rid of it completely. And of course there's nuance and there's a lot of things in the middle. And I think you nicely portrayed a pretty reasonable, science-informed, patient-centered approach to manual therapy that I don't, think a lot of us can argue with. I'm sure some people.
I don't think anybody out there who's working in clinic who actually sees patients, I don't think they have much tolerance for either extreme. Honestly,
yeah.
I mean, I'm sure it gets clicks and all that kind of stuff, but most people in the clinic, I think they would immediately recognize that as not a tenable position clinically.
Yeah.
Regardless of what their background was. It reminds me of being stuck in the middle on two ends of the political stuff. I think most people live in a pretty big middle, and just because the outside people are loud doesn't mean there are more of them or they're more popular or that they're right.
Yeah, exactly. And some of the extremes are the ones that are loudest too. That are yelling the loudest.
That's part of being extreme, right? Is being loud and having a strong opinion. I think that's great. Get it out there. Let's talk about it. I mean, that sort of difficult conversation moves us forward.
Yep, I completely agree. All right, well, thank you for that. Let's go on to our next question. We got Prashant. I'm not going to go for the last name, Prashant, so I apologize for that. But why is physical therapy evidence-based practice not reflected in clinical practice? So evidence-based practice not being seen in the clinic. What are your thoughts there?
Oh, that's an easy question. It's because we're humans.
And next question. No, go.
Yeah. My interpretation of the question is, why don't people change their behavior when presented with compelling evidence? And I guess my best response is because they're humans, because they've got all the biases that we all have. Like, this problem is not unique to PT, right? So So kind of probably like you, like I'm not just in PT. I've kind of got a foot in the fitness world too. I've spoken at a couple of fitness conferences. I have a lot of fitness folks on their as social media contacts. I watch some of those discussions play out, and it's funny. And every place you go, in any group or industry, they all say the same. The problem with people in our industry is blank, and in that blank, they put some sort of timeless human fallibility, right? That's true of every single one of us. That happens in every industry, but they think it's only a problem in their industry, right? And so, the problem with personal trainers is blank. I'm like, well, no, everybody's like that, not just trainers. Everybody's like that, not just PTs, right? So we have the exact same problems with applying evidence and changing behavior that every single other group of people has. So the question for us is, what do we do about that? And I think there's a lot of things that we can do to help move things forward. I think APTA and the American Physical Therapy Association, our professional associations have a role to play there. I think our schools have a role to play there. I think our postgraduate groups have a role to play to do that. I don't think that my behavior really changed clinically a great deal in a massive way until I went to a residency or fellowship program. And in a fellowship program, when I had sustained interactions with a group of mentors who changed my behavior deliberately, as my program director, Skip Gill, said, we're going to scrape around inside your brain and figure out how you think and help you think better. And that's really what the fellowship experience was about for me. Not about learning manual therapy techniques. It was learning how to think and how to reason and how to apply that to the clinic. And it just happened to have a side effect to apply to a lot of other things in life. I mean, once you learn some of those principles of clear thinking, they don't just apply to one thing. They apply it, across a range of a lot of things. And so we have those same challenges. And so just giving people information doesn't tend to change behavior, right? So I'm in hospital leadership at a very large military hospital in the DC area right now. And so one of the things I confront all the time is the need to change policies and processes at our hospital. And there's a lot of people who I will sit in meetings as we talk about this and say, we just need to educate people about XYZ. And it's hard for me to not laugh when I hear that. Education doesn't change behavior. Education doesn't change behavior. Education does not change behavior, right? So in an organized healthcare system, right, a clear process, audits and compliance checks change behavior, right? So the idea that people are going to get new information and automatically change your behavior, it doesn't work. It's not a thing. Here's an idea. Maybe we should stop talking about it. I'm not saying we shouldn't educate people. By all means do. But give them something in return. Give them a process to follow in return. And I think that's often what we don't do well in medicine. We talk to people about things that they shouldn't do or things that are outdated or processes that maybe are suboptimal, but we don't replace it with something that will work for them. And it's hard to do that unless you have an ongoing relationship with someone and you can see what they're doing in clinic or where they're at. And that's why things like mentorship experiences, whether online or in person or whatever, that's one of the reasons that they're so valuable. Is that's really how we change people's behavior individually as clinicians. Your peer review process, if it's run well at your clinic, can help accomplish this, where you sit down, you don't just check and say, yeah, okay, you didn't do anything dangerous. Well, no, it's a little more to it than that, right? You can have a successful peer review process that actually helps change people's behavior, where you sit down and say, hey, I looked at your note here. I noticed you did that. Did you consider this instead? Or, what was your rationale for that? And as people talk through it, it can be improved that way. So we have the exact same problems with knowledge translation and behavior change that every single other organization and every single other industry has. And until I think we realize that and start finding ways to apply it that aren't just based on throwing information at people, I don't think it'll change.
You bring up some great points there. I think that critical thinking piece that you get in fellowship and that external source of evaluating your thinking and then challenging you to evaluate your own thinking, that metacognitive piece, I think is priceless. And that should not be unique to manual therapy training. I think that needs to be, and I think a lot of other fellowships and residencies push that, but that is such a huge thing.
Yeah. Couldn't agree more.
Yeah. So let me get on to the next question here. We have Andrew Imrie. I apologize again if I'm butchering names. How do we go about identifying, promoting, and supporting the very small intersection of evidence-based, individually tailored healthcare and running an ethically sound, sustainable PT business. It strikes me in many ways what is best for one is not best for the other.
Yeah, I'm not sure I 100% understand his question, but I'd like to restate his question out to video. And Andrew, if you're watching, you could clarify in the comments perhaps. But so I sometimes run into people who will ask about some of the business aspects of therapy and the business aspects of medicine. And my first disclaimer here is almost all of my 21 years, I mean, I did spend less than a year out in the real world, and the whole rest of the time has been in practice in the federal system. Like we do coding, we do medical coding, we have productivity requirements, all those things are the same. But I don't know about like insurance payment or dealing with insurance companies. I have zero information about those things. And so I may not be the right person to ask that question. But I would say, as the second part of this is that people will often express frustration of talking about how like evidence-based practice, like it isn't profitable or it doesn't bring enough business in or something like that. And I'm not sure how to respond to that. So I would say that in a physical therapy clinic that I'm in recently, I'm usually the oldest or the most experienced, or if not close. And in terms of expertise, I'm usually at the top, and I'm towards the top. And I realize that might sound arrogant, but I want people to understand that based on my past experience, based on the training and stuff that the Army and other people have put me through, that's why I'm saying that. So I would say that I never have trouble filling my slots. People hear about me, people want to come see me, other people consult. I mean, I never sit around with nothing to do, right? And if I can turn somebody around and help them feel better in a smaller number of visits, they go out and they tell other people about that. They go out and they talk to other people, and other people in my clinic hear about that. They're like, oh, well, that was only 4 visits and he didn't get like, hot pack and E-stim and some other, why didn't you have him working on his core and that kind of stuff? And so I would say that good evidence-based practice, I think, is more profitable rather than less. I think that if you are charging the same amount of money for the service that you provide, that you have good reason, objective reason to think is better quality, and you're charging the same amount as somebody who's providing a worse service, like that's just economics. Like I can't help you understand that, right? I mean, you should be charging what you're worth and what the worth of the service that you're providing, is worth in the market or to your patients. Like I'm going to eventually get out of the Army, so I'm told. There will be little fingernail marks on the ground as they drag me out. But sooner or later, such a day is going to happen, right? And I'm going to start seeing patients in private practice to some degree. Seeing me is not the same as seeing somebody with 2 years of experience who doesn't have the same background. I mean, it's not. I mean, that's not arrogance. That's just fact. I'm just a lot better than that person is. And I have no trouble coming up with a fee schedule that makes that worthwhile. And if my fee schedule is done right, I probably have time and I probably have space in my budget for pro bono work on top of that, for people who need these services and can't access them. And even if I don't have time in my day to do that kind of pro bono work, if I'm charging a kind of fee schedule that supports the service that I'm providing, I probably have money on top of that to contribute to help take care of people who are in need and can't access my services just, financially. I do think that's one of our responsibilities in healthcare. It's not only to provide the best care we can, but it's also to try to take care of people who don't have as many healthcare options, people who are less fortunate, people who are, don't have the coverage or need services and can't access them. I do think that's part of our responsibility as healthcare providers. I don't think that makes me a communist, right? So, but I think both of those things are in play. So I think, first of all, if what you're providing people is better than what the average PT clinic downtown, so to speak, is charging, and you're charging them the same amount and you're wondering why you're not profitable, I think we found your problem. I'm not sure if I've misinterpreted the question, but that to my understanding, that's what I'm being asked. So there you have it. Andrew, I hope that answers. If not, please help us understand better what you're looking for.
I haven't seen Andrew come on, but I think he nailed it pretty much from my perception of that question was and what they were asking. And I think you bring up some great points about valuing what we do and not undervaluing and not racing to the bottom to compete with folks that are providing low value treatment and try to, value what we're bringing to the table, charge for it appropriately. And then, like you said, I love the model of being able to set a fee schedule that values what you do and then gives you the opportunity to provide those services to those people that can't access them. That's the exact model I'm going to be going after myself. And I see Tony Maritato's on here. I've talked to Tony before. He's a big proponent of that exact model as well. As far as, valuing what we do and being okay charging for it if you have the experience and expertise.
It's not just PTs either that you're comparing. You're comparing against other healthcare providers, right?
Yeah. No, absolutely.
If you have a musculoskeletal problem, you are much better off coming to see me than almost anybody else in the healthcare system. An experienced and qualified DPT, you are far better off seeing that person than seeing somebody in primary care or in specialty orthopedic care or anything else. Just based on not my opinion or not my professional bias, but just based on what the literature is telling us about things that are and are not successful, that are and are not expensive, that are and are not risky. We can absolutely make that case with objective data, and we need to stop being shy or uncertain about that, and we need to push out and be proud of the quality of the service we're providing.
Yeah, I think we have this we're scared to put ourselves out there in PT. I don't know what it is in our profession, but we just do not market ourselves. We do not push the message out, and that's kind of one of my big pushes lately is to say, how do we put a message out in the public instead of complaining about all the other messages out there from other healthcare people? Instead of, why don't we control what we can control and put a better message out there that drives that exact fee schedule and ability to see and charge the way we want to. We need to be better at marketing, better at giving people an appropriate message that science-based, that we can go to bed at night feeling comfortable that we're giving to the public and doing a good service. I mean, you hit it on the nail on the head. We have so much literature that isn't opinion-based, that isn't bias-based, that is just literature that supports that we are the best people to see a lot of these conditions. And I think we have a moral and public, duty to let people know about it. And we don't do it good enough, for sure.
Yeah, that's a good way to put it. I do think that that's part of our moral responsibility as well. I think, the medical system, I can't speak for other countries so much. I know Germany's a little bit, but I really know the one in the States. And that system is well and truly rigged in a certain direction. And it's rigged to keep supporting people who make the most money and continue to allow them to seize that market and push out anyone who's competing with them. I mean, that's just the facts. And it doesn't mean that everybody in those groups are bad. In fact, most of them are great. It's just some of that we raise people up through the system, through training and through education. We raise them up to not see themselves as valuable as what Joint Commission would call licensed independent practitioners. And that's really, we need to grab hold of that and be confident and know that there's good data that encourages that. I've really come around to John Childs' position that I remember arguing about him years ago. And John would say, look, even if the PT care isn't the best or isn't what all of us on this call or who are watching right now would provide, even so-so or not so good PT is better than what people are getting but with the average practitioner other places. And at first I was really reluctant to accept that. And I was very dissatisfied and constantly vocal about how bad other people in PT were. And over time, as I've looked at the data, I've changed my mind. And I think he's right about that.
Yeah. He's published some interesting studies, some healthcare system research that kind of supports that view. So it is something that I think we have to be more comfortable with, that kind of thought process, even if it isn't the perfect scenario. It's better than an expensive biomedical, costly, disabling approach that sometimes is out there. So it's a great point. Let's move on to some other questions. I want to make sure I get to other folks' questions here. Samad PT from, I believe, Nepal. Good to have you asking some questions here, sir. What strategies do you follow to push the patient in their own control or self-management strategies with chronic musculoskeletal pain?
Yeah, good question. I would say that a lot of that really depends on what the patient gives me. I think that early on, especially before I had a lot of, mentorship-based training, I was really focused on doing a lot of prep before the visit. Like what do I need to tell them, and what strategies should I use to do X, Y, and Z? And I really think that's the wrong way to look at this. I really think that you need a framework to use to communicate and help people. And there's some motivational interviewing is a framework. Cognitive functional therapy is a good framework. You've heard, Peter O'Sullivan and other people talk about that. I think that's a valuable framework. Get your framework down, understand some basic strategies from your framework. And instead of pulling away from the challenge and trying to preset yourself, move toward the issue, move toward your patient, talk to them first, figure out what their main issue is, find that thing and address that thing. I tend to try to locate what I think is the patient's biggest barrier in terms of pushing out to an external locus of control, and what the patient feels their biggest personal barriers are. And I kind of start there and move down. I use a little bit of a Socratic questioning kind of a thing and a motivational interviewing to try to determine, okay, what's this patient's primary concern? And let's figure out whatever their primary concern is. I need to start working on that on day one. I need to engage my patient. I need to make sure that they don't have any sort of emergent type of medical condition. It means they don't belong in my clinic, that they belong in an ER somewhere, for example. And that does happen, as we all know. And the third thing I need to do is I need to figure out what their main issue is. And I need to start talking about and addressing their main issue on day one. And it really does depend on what the patient gives me. Sometimes it's about their imaging results. Sometimes it's a fear about bodily damage, and that's where I start. Sometimes it's issues at work with work stress or work excusal or something like that is occupationally related, and that's where I start. What I think we can't do is we can't set up in our mind how things are going to go and then put in and try to push that framework on our patient. That's not going to be successful. You really need to develop a couple of these strategies, and then sort of get in the clinic in that interact and just let that back and forth guide you, right?
So you're saying the patient should kind of drive the encounter, not the clinician. I mean,
yeah. So I don't set the agenda, and me trying to set the agenda first is just a recipe for disappointment for them and for me.
Yeah, no, and you think that sounds like now after, kind of as we read and we hear stories of Gilletta Beltons and Keith Meldrums and other folks out there, you think that
it's a great example.
Yeah, they're great examples. But, and then you look back, at least for me, I look back at my career and how I always had this agenda that was like my agenda. It was maybe this is the questions I'm going to ask some people. And it's really, that's one of the big things that's changed in my practice. And I don't know about yours, but as far as really even more moving towards that patient-centered approach. Sometimes we say it with lip service, but I don't think we've maybe as truly done it as we probably should have. And then when we hear stories of, man, how that's the most powerful part of often the ability to help somebody, it sure makes sense that we should be prioritizing that.
I think your point about sometimes people who build themselves as patient-centered really aren't. I mean, I don't think that's such an important point. I think it's worth talking about briefly. I mean, listen to the stories of what some of our vocal patients are saying, right? Joletta Belton's a great example. If you're smart, you will listen to what Joletta has to say, because she has a lot of ways that we can improve. And if we're smart and if we listen, we can improve. Some people who say that they're patient-centered still kind of have this sort of paternalistic, down-talking kind of approach. And I've seen this in clinic, and it turns me off, right? And so we really need to let the patient set the agenda of what's discussed, and we need to start working on addressing what their concerns are. And instead of trying to set ourselves up as the knowledgeable guru on a mountain, we need to Corey Blickenstaff talks about being a contextual architect, like building a context. So patients who come in, I'm trying to help them continue their story. And in their story, they're the hero, not me, right? I'm Yoda from Star Wars. I'm Alfred I heard Rod Henderson talk about, most people talk about how they want to be Batman. He said, what you really need to do is you need to try to be Alfred, right? You need to be the person behind the scenes who's got the cool gadgets and the wise advice and all that stuff, who helps people get things done themselves. And you look back at some of the things that Joletta has talked about, she didn't get any of that. Like, it wasn't even close, right? Even what you would look at the things that we tend to argue about in PT circles, on social media and elsewhere, it's all treatment stuff, right? It's, did you do this approach instead of that approach? And if you're listening to patient panels at conferences, man, that's the least important part of this whole thing. It's the least important. We spend all of our time, all of our opportunity that we've got to address the patient, we spend almost no time on it. And all the small opportunity we have to fiddle with what approaches we're using, that's where we put all our time and attention. It's totally reversed.
Yeah, and I think hopefully this movement of patients coming into conferences and these stories, where it should hopefully slap us in the face that maybe we need to stop pontificating on social media and grouping up with a bunch of fellow clinicians about what patients should be doing. And maybe we should actually ask the patient. Maybe we should actually talk to them and listen to them and hear what their thoughts are.
Yeah, that's exactly right, and that's what I try to do every day.
Yeah, no, I think that's a great approach, and one that I think our patients are more and more thankful for, especially the ones that have navigated that journey that, you know, Joletta and Keith and Pete Moore and other folks have navigated. So let's go into the next question. Suzanne Thorson is a Canadian physio in the armed forces that are in Canada, and she's wondering what challenges you face that are unique to military servicemen and what frustrations you face in your particular clinic. In her particular base, it would appear that a lack of collaboration among the various practitioners is number one. And with her and some of her colleagues, as an armed service, we deal with too many complaints regarding footwear. I would love to compare.
Okay. Yeah, well, most all my time has been in medicine has been in the military. So it's with active duty service members, with their families, with retired service members and their families, right? And so, you know, what's funny is that that experience in that community, it still seems to translate enough that people like you ask me to come talk to people who are not in the military. So I would say, first of all, probably most everything that I'm facing in clinic is the same thing people are facing outside the military. I mean, people don't stop being people because they put uniforms on, for better and for worse. So I would say that on her comment about footwear, I really don't get that a lot. I mean, people who are not used to being on their feet and marching and doing military things are going to have foot complaints. And I would say that is mostly a question of training load and much less a question of, you know, exact footwear. And I do think that the science is pointing us in that direction. I think the collaboration in the federal system is on balance, appears to me, from my anecdotal perspective, it appears to be better than in most clinics in healthcare systems outside the military. But that my lens is very United States based and very, based on what my experiences have been so far. So I don't know if that would really translate to other situations, but I think that's the case, at least for me. I think we collaborate pretty well. I think probably the biggest challenge that we've got that isn't what happens in the civilian, because like challenges about imaging studies and about, you know, what the diagnosis is and like all that full spectrum of issues that you got in the civilian world, we still have in the military. I would say on top of that, people often in the military feel pressured to make a medical decision for a military reason. Let me give you an example. Like, hey, doc, I've got this knee issue. I need to go to this course where I need to perform in the military in 3 months. I think I should have the surgery now so I can recover before I go to the course, right? And so I think they're mixing things up. What I tell people is, don't make a medical decision for an administrative reason. So don't make a decision about your health based on factors that aren't health related, right? So if you rush yourself into that surgery, sure, you might get through that arthroscopic surgery and you may be able to successfully rehab well enough to be able to successfully compete in this military course you need to go to. But also you might not be any better off with the surgery than you are with the rehab. You may have an adverse outcome or a side effect or issue from the surgery that you're not at risk of getting with the therapy program, and you're sort of rolling the dice either way. You got to make the best decision you have with the information in front of you. And putting an artificial timeline on top of that decision that is not related to your medical care is a mistake. And I've seen it turn out not so well as seen it turn out okay. It really just depends. So I would say that's probably the biggest thing that I can think of right now that's different. It's probably 99% the same. We have the same issues inside the system as we have outside.
All right. Well, thank you for that. Let me move on to the next one. Tanya Velasquez, if you had only 5 minutes to communicate and hope to reframe a patient's/client's belief that pain does not equal tissue damage, or their belief, the client's belief is that pain does equal tissue damage, what would you consider to be the key point to underline, and how would we drive that message home? So 5 minutes, change somebody's beliefs.
And go. So this may feel like a dodge, and I think, Tanya is I hope that's the right way to pronounce your name, is very thoughtful. And it's a good question, but I would say that I think we're already started down the wrong path here for two reasons. I think the first one is we're trying to prep or put a framework on a visit when we're not in the room with the patient, and that's usually a mistake, right? And so, as we say in the military, no plan survives first contact with the enemy, right? Mike Tyson once said about people's strategies in the boxing ring, he says, everybody's got a plan until they get punched in the face, right? So I had great plans early in my career of exactly how I was going to educate people and all my little examples and everything. And then I got in the room and tried to apply those things in a way that the patient didn't understand or didn't engage them, which is my responsibility, not theirs. And it just went poorly. So I would say the first thing is make sure we're addressing the patient's primary concern on the first day. And the only way to determine what that primary concern is you have to talk to them and try to work it out together. I usually use this with questioning, motivational interviewing style or otherwise. I know you mentioned the MRI a couple times, and you're concerned about the cartilage loss that the MRI showed. Would you like to talk a little more about that? So that's one example to help try to figure out what the patient's primary concern is. And, I have a supply of metaphors and examples I use. I'm sure you do. I'm sure everybody watching or listening does that too, that I can apply. But it really does depend on what the patient is about and what their concerns are. Because she's asked a specific question, I guess I should give some sort of specific answer other than just dodging her question. So when it comes to pain and tissue damage, and I talk about imaging, one example I use, I have a lot, is taking a picture. I said, look, a picture will tell you what you look like. It doesn't tell you what you feel like. So if I took your picture and I did a little nonverbal, I can tell you what you look like, but I can't tell you what your pain level is. I can't tell you how worried you are about your back or your knee or whatever. Right? The picture doesn't convey how you feel or doesn't convey the health of your body right now. And that's what that MRI is. It's a picture. And the main purpose of that picture is everything in place where it's supposed to be? Yes, it is. Is anything major ruptured or injured requiring immediate repair? No, it's not. And that's the purpose of that picture. Once the picture is done, now you actually have to talk to somebody to figure out what they're feeling and all those other things. Looking at a picture of them does not tell you who they are, does not tell you what they can and can't do, right?
No, that's a good way to look at it. And I think I'm going to have to file that story in I always love collecting stories from other clinicians. I think we all kind of grab them from folks that we've learned from. So
Lorimer Mosley's book that came out on metaphors, which the title of which is escaping me, which I'm
Painful Yarns.
Painful Yarns. Thank you. Painful Yarns is a great example of those. What struck me most about Painful Yarns was not how insightful and clever the examples were, which is Lorimer Mosley, so I'm not surprised. I was surprised how many of them I had a hard time understanding because they were written by an Australian, right? So this is a perfect opportunity to chat a little bit about the impact of people's cultural beliefs and their cultural background on their understanding of their problem, right? Mm-hmm. And how difficult it would be to cross that gulf with somebody who's got a much different cultural background than you do. Not that you shouldn't try and that you shouldn't try to find ways to engage them. You should, but it definitely gives you a picture of how different we can be based on our backgrounds, even though we might be similar in a lot of other ways. And you can see some of the challenges that are there. I mean, I read those stories that in every story, there's a word like, I don't even know what that word means. Right. So I've got some social media contacts, friends on social media who are from the UK. And like, I love reading their posts because in almost every post, there's a word I don't even understand what it means. And I'm speaking the same language. Like, right. We were a British colony and like interesting. I'm reading this thing. It's like, I don't even know what this guy is saying. Right. And that's the same language. That gives you an idea of how tricky that can be. And therefore it also gives you an idea of how tailored that needs to be to the actual person sitting in front of you. And it's really hard to program it or structure it ahead of time.
Yeah. It's kind of got to be kind of that clinical chameleon approach that kind of finds where the patient's at and you try to mold yourself to where they're at and their beliefs and their culture. And a lot harder than just a standardized program, and it makes it a little bit more uncomfortable. But I think that when you can get into that gray area with the patient and try to weed through that mire with them, I think, man, you can have some rewarding outcomes with it. I'm sure you can relate to that.
Totally.
We got Zach Gabber. I hope I'm not butchering your name, Zach. But anyway, in your opinion, what do you believe is to be the highest ranking or the most important active ingredient that allows all the different paradigms / systems to be successful?
All right, I'm going to give you a glass half empty and a glass half full response to that. I see I have the sunlight coming through, so you can get a really good look at my chin right now. So nice, good chin. So my glass half empty response is that it's a lot more about patient engagement and your personal connection with the patient and those non-specific effects than any of us are comfortable admitting for the most part, right? So the first part is if you're engaging and you connect with someone and you're working with them through this process, then chances are they're going to do well regardless of what it is that you do. And so that's that's the sort of negative way to look at it. I would say the positive way to look at it is there's a lot of different systems and processes out there you can use in clinic. And so Mark and I just talked about a couple of them. One's Maitland, one is McKenzie. They're named after the people who created them. I would say that we often don't do a good job of giving people a replacement reasoning process when we take away something that they're already doing by telling them that it's no longer evidence-based or no longer a good idea for the patient. We don't replace that with a reasoning model. And without a reasoning model that helps you decide what to do next and how to progress things, people get lost all the time. And we do a rotten job in the clinic, in our education programs, of giving people a paradigm that they can use. And that is, we have the same kind of challenges that way as people in behavioral health have. As psychiatrists, psychologists, and social workers, when they're working with people who've got challenges in the behavioral health realm, there's a lot of, they have all the same disagreements we have. They've got all the same people who are like, oh, I've got this brand new system and it's great and it fixes everything in 3 visits. And it's the exact same kind of challenges that we've got, right? So I would say that we have a lot of different systems out there that do a good job of giving people a reasoning process, a reasoning model to use. And regardless of exactly what your intervention is, if you have a good reasoning model that allows you to find the best targets for your interventions, whatever they are, chances are you're going to do pretty well, even if the interventions might differ.
Yeah, I always go back to that Gifford quote where he talks about if you could only all realize you're doing the same thing, playing with processing, you'd help a great deal more and sell a great deal less. Yeah. That's a great quote. And I think, there's a lot of the contextual architecture that you speak of that Corey Blickenstaff kind of coined, I think is an important thing. That is a skilled thing. I mean, as far as really being able to create a context, it's not just simply, playing nice music in the background and, creating this nice spa-like atmosphere. There's a lot of active, purposeful things. And I love what you say about reasoning, because I think that is one of the things that students miss and even practicing clinicians miss is we don't get that kind of framework that should take whatever system, whatever treatment, and we need to be able to validate it through some reasoning process or invalidate it, either or. Yep. And that's, I think, a big push that we're trying to do with our group and with others, as far as just trying to give people that, hey, maybe we can all do different things and it's okay, but we all have to have some sort of patient-centered reasoning framework that allows us to kind of validate it within what we're doing, and not getting so dogmatic and minutia driven sometimes with it. But
yeah, that's the deal. I think we need to we in the like evidence-based practice arena, for lack of a better term, we need to do a better job of giving people, of putting emphases on reasoning models. I wrote a shameless self-promotion alert. I wrote a letter to the editor a while back it's called Manual Therapy, Process or Product, that kind of gets at how I feel about this distinction. We need to teach people useful processes. Exactly what they end up doing is so much less important. I mean, we always want to argue about what the products are, and so I think that the process that I use, I'm pretty satisfied with. I think that I could use that same process, and if I put something else into it in terms of an intervention that maybe I don't do now, that maybe I could, like dry needling, for example, I still think my process would be pretty successful. That's not the intervention that I'm accustomed to using. It's not for me. It's not my cup of tea, but I don't think it's wrong either. And I think that you could be used in a good process to get good results.
Yeah, no, I think the process is, and again, I think sometimes we get so invested, and I can just speak for myself. I had periods in my career where I was so invested and defined by the product. Like it was this treatment or this system that was the solution. And, and I think sometimes the biggest thing that I think helped me, and it sounds like also helped you, was just learning that framework that has to be that whatever you decide is the way you want to approach whatever product you decide to use, it needs to have a process to be validated with that patient each session, that it's actually creating change in a positive direction for patients. I like what you're saying there. Bear with me 1 second, because I'm going to bring up because I know we've had comments coming up all over the place. I know there's one that was a question. I'm going to try to bring up this.
Okay. I'm going to shift a little bit to see if I can stop illuminating my chin with the sunlight. So.
Well, I think, is this your Movember mustache you have going there? Is that just
It is. I hope it's not disturbing too many people. This is the Movember mustache. It's only 1 month a year, and I don't do it every time for obvious reasons.
I mean, it's a regal looking mustache. I think it's for a great cause.
My face is a little narrow. The mustache gets a little narrow, and it's always dicey territory. Without making a Godwin reference, it's always dicey territory. So,
you know what? For some reason, I can't page down to any further comments or questions on the post, and I only think I saw one. So I hope if anybody else has any questions, I'd love you to post them up on the page. But any other things you think would be worth, any things of value that you can share for the folks here? This is a group that we have that is just people from all over the world, from massage therapists to chiropractors to myotherapists to physical therapists to trainers to everything. Any kind of words of wisdom, based on some of the things we've discussed, of like how to go forward, maybe with a, more science-informed, patient-centered approach. I know that's a loaded, broad question, but I'm just curious what your thoughts may be with that, or maybe how can somebody best move forward in that kind of light?
Yeah. Okay. So you just mentioned a lot of different groups, right? We have people who are, physical therapists, or, physicians, or massage people, or chiropractors, or whatever. I think my first thing is detach yourself from the tribalistic foolishness of which profession is which and which profession is better and all that kind of stuff. Allow the professional associations to play out their, petty little wars. That's fine by me, right? I'm looking for a different tribe. I'm looking for a tribe of like-minded people who are driven by science and evidence, who put the patient at the center of everything that they do, and are collaborative and willing to work with others. Regardless of what the letters are behind your name, I literally do not care. Some of the best people that I've worked with have been from people outside PT. Some of the best people that I've had ongoing interactions with, that I think some of the people who do some of the best work, or who potentially can do some of the best work for our patients, are people outside of medicine, but who have long-term relationships with patients. Personal trainers and massage therapists come to mind, right? So I think those people are far more important for somebody's overall health and fitness than I will ever be. And I am totally okay with that. I'm the medical guy who does the medical stuff, 2, 3, 4, maybe 6 to 8 visits, and we're done. I mean, can you come back to see me for something else? You sure can. Would love to see you, right? But that's not the same as the massage therapist you go to every month. It's not the same as the personal trainer you go to once a week. Those folks have tremendous power to help steer people in the direction of great, healthy choices, to steer people in the direction of making good choices for their health, for their fitness, and their long-term function. I think that we need to do a better job in medicine of embracing those people, bringing them in and developing better relationships with them, and engaging with them better than we have. I think that people in the training and massage communities are almost always better than us in medicine at being collaborative and reaching out to other people. So those are two of my favorite groups in terms of helping people be healthier and make better health choices. Are people in the massage and fitness communities. And if you're in those communities, don't let anybody in medicine get, smug or talk down to you about what you can do for patients, because they're wrong. Yeah. You have tremendous power to help people.
Yeah, and I love it, because I think, I don't know how anybody can look at what we do with patient care and think that there's one profession that's going to have it all figured out and solved. And I do think there's been periods of my life too where I had this clinical ego and, man, I have it all figured out, and the patients just can just be a PT for life patient, and we're going to have it all fixed and figured out. They don't need, but there's such value in collaborating I've collaborated with chiropractors, I've collaborated with personal trainers and massage therapists, and huge value, especially if you can all sing the same message to somebody and you're moving them towards self-efficacy and internal locus control and getting, living a better life and pursuing their valued goals. If you can be a stop on the road to helping that person live well, then, man, I think we can all work together. And if you just give each other the chance and suspend egos and recognize we're all on the same team, we can make a huge impact in people's lives. So
I would say, in addition to that, there's also nothing wrong with advocating for your profession and what those people can do, especially if the system that you work in biases away from low cost, low risk, quality care. So I do a fair amount of promoting early PT, dare I say, get PT first. And I'm not sorry about that. And I don't think I should be, but I think you can do both. You can both advocate for better access to care for what people in your profession can do, while also being collaborative across different professions. See, normally my cat would be walking across and you'd see his gray tail pass back and forth. But the reason he's not all over me right now is that he's actually at the vet getting his shots and his comprehensive care. So,
yeah, my daughter's banging on the door to get in here, so she's going to make a cameo, and then I'm going to hand her off.
Oh, awesome! If I don't have my cat, we can at least have your daughter.
Yeah. So she wanted a guest appearance on the podcast today. So
hey, there we go.
Honey. Say hi, honey.
Oh, hi.
Yeah. So she wants to hang out with Dad, and I'm actually about out of time myself here.
Okay.
Thank you. She's probably gonna squawk a little bit, but anyway, I totally lost train of thought. I apologize, but she was banging on the door. Okay. So, any other thoughts, things you want to mention before we sign off for today, Jason?
I would say that. I think if we kind of review some of the themes that you and I talked about today, one of them to me was put less time and effort into preloading what you're going to do with a patient before you step into the office with them. Spend more time using a framework that helps you be flexible and follow the patient where they lead, and make sure that when you say you're being patient-centered, you're not just repackaging paternalistic, I know best medical speak to them in a different way, because a lot of people are doing that. I should know, I've seen it. And unfortunately, there have been times in the past when I've done that too, full disclosure. I'm certainly not perfect. I made tons of mistakes before too. So I would say, put yourself in with the patient and really let the patient take the lead, address their primary concern, address that up front on the first day, and in a way that matches their understanding. And you can use things like motivational interviewing, or a Socratic questioning style, or like a cognitive functional therapy style of interaction to help you achieve that. And I think those are some of the big themes that we talked about today, as well as being collaborative and not being afraid to look outside your profession for valuable allies in helping you take care of patients in an evidence-based and patient-centered way.
Love it. I love it. I mean, that's a great summary of what we spoke about. And I can't thank you enough. There were so many, great tidbits that you spoke about today that I think will bring value to everybody in this group. And I hope you guys share this out to other folks, because I think it's a discussion that was very refreshing and was great. And I think it would benefit not just, patients would be beneficial to hear this too, of what ideal healthcare should look like for them. So definitely share this around to your friends, to your family, to your colleagues, and let's help move things forward in a better direction. And I think, Jason, I can't thank you enough for your influence on my career personally, but also the influence you've had across our profession and across other professions, personal trainers, chiropractors, everybody. I think there's a lot of folks in those professions that have a lot of respect for you and are very thankful for the things you're doing to push us all forward. I'm going to link your article, Process versus Product, in the page here so folks can take a read of that, because I do think that's a good read for everybody. So thank you so much, Jason. I'm going to sign off for the rest of the day. Thank you, everybody who joined us today. I saw we had a bunch of people online. I appreciate your interaction with us today. And let's
love to come back.
Yeah, we'll definitely love to have you back, and we'll see if we can structure some other ways to get you on and sharing some of your wisdom, because I think it's a great benefit for folks. So thank you so much.
You guys are paying it forward and doing a great job. I mean, at the end of the day, it's changing people's behavior is difficult outside of like an ongoing mentorship interaction. So like to sign off, one of my social media contacts, so I've seen it conferences before, Dr. Deborah Joy Sheldon has a pain mentorship program. She's doing a lot of what we're talking about right now. Mm-hmm. She is giving people a framework. She's showing them what to actually do, because I think that we don't do a good job of that. And so mentorship programs like, Mark, the one that you are running is extremely valuable. Mentorship programs, the way Deborah Joy Sheldon is running, are extremely valuable. If you really want to change what you do, you've got to get involved in some kind of ongoing mentorship. You really can't pick it up piecemeal from different places online. It will be helpful, but if you really want to seriously change how you approach something, there has to be a mentorship component and an ongoing commitment to change. And those are two good resources for people to use.
Yeah, no, I appreciate you bringing that up, because that's exactly what we're trying to do with our virtual mentorship, is leveraging virtual meetings, Zoom meetings, and all these things to get into people's heads, to get into their thinking, to get into the process-driven care, to where they can still have their strengths of what they do from a product perspective, but we're going to give processes to people and give them the ability to do a lot of the stuff we just talked about today. So yeah, I appreciate
great stuff. You guys are doing great work. Keep it up. I'm happy to come back anytime.
All right. Thank you, Jason. You have a good rest of your day.
Thanks. Bye-bye.
See ya.